Assalamu alaikum. Welcome to our channel Park Medicos. Today we are going to discuss our one of the most important topic in medicine and also in our life, myocardial infarction and on an other hand heart attack. Before I am going to start my topic, I requested to all of you kindly subscribe, share and like and comment my channel and never forget to press bell icon for our new video notification. Without wastage of time, I'm going to start my topic myocardial infarction, one of the most common diagnosis in hospital patient. Mortality rate from acute myocardial infarction is 30%, more than half of these deaths occurring before the strikes individual reaches the hospital. So you can imagine that how much it is dangerous, how much it is important to know all about this. What is acute MI usually occur when coronary blood flow decreases abruptly after a thrombotic occlusion of a coronary artery previously affected by atherosclerosis. What I want to say, I'm saying that when a coronary artery that is previously atherosclerosis, his this artery flow is compromised due to its lumen compromise, any thrombotic event, so it will lead to blood flow decrease that will lead to myocardial infarction. When a coronary artery thrombus developed rapidly at a site of vascular injury, number two, and number three, injury facilitated by factor. There are multiple factors that will lead to these endothelial injury. These are what? Cigarette smoking, hypertension, lipid accumulation. What is the pathogenesis of MI? Pathogenesis, atherosclerosis plaque disruption. Any atherosclerotic plaque disruption that is present may be femoral artery that will be travel embolism and will lead to adhere at the coronary artery. After this, thrombogenesis. Any factor that will lead to thrombogenesis will lead to a clot formation in the coronary artery. Then thrombogenesis will lead to platelet activation. This platelet activation will lead to platelet activation. Platelet aggregation will lead to cross-linking. Cross-linking will lead to coagulation cascade activated. So this will all process will lead to a formation of thrombotic plaque in the blood vessel that will lead to occlusion of the blood vessel. After this, the amount of myocardial damage depends on territory supplied by the affected vessel, whether or not the vessel become totally occluded or the duration of coronary. This is very important. This vessel is totally occluded or partially occluded, and what is the duration? What is the duration of coronary occlusion? Then the quantity of blood supply by collateral vessel to the affected tissue, how much collateral are present at here. Then the demand for oxygen of the MI whose blood supply has been suddenly limited. What is the demand of oxygen for this myocardium who is suddenly limited? Then native factor that can produce early spontaneous lysis of the occlusion thrombus. The adequacy of myocardial perfusion and the infarct zone when flow is restored in occluded epicardium coronary artery. What are the risk factors? There are multiple risk factors that will lead to MI. So these are, I will discuss this. Person with multiple coronary risk factor, person with unstable angina, person who has unstable angina also, and hypercoagulability, collagen vascular disease, cocaine abuse, intracardiac thrombus or mass that can produce coronary emboli, and also a fatty a person who is obese, diabetes patient, or patient who is using cigarette smoking, and hypertension patient. What is the clinical presentation? Usually soon after awakening. Pain, most common presenting complaint, deep, visceral, heavy, squeezing, crushing pain. A person say this is the worst pain of my life. Crushing pain, stabbing, burning, similar to angina pectoris but occur at rest. It will radiate to shoulder, neck, maybe epigastrium. Most severe, last longer, not immediately by rest. In angina pectoris, you know that when the patient is at rest, the pain will be settled down, but in MI, it will not be settled down. Central portion of the chest, epigastrium, radiate to the arm, sense weakness, sweating, nausea, vomiting, anxiety, and a sense of impending doom. Then what will be the finding? Anxious and restless, pallor, perspiration, physical sign of ventricular dysfunction, fourth and third heart sound, decrease intensity of the first heart sound, and paradoxical splitting of the second heart sound. These are the findings you will find. What will be the lab in finding at ECG, ST segment elevation, there will be a ST segment elevation, and there will be one other type that we call non-STEMI. I will explain in another video. And serum cardiac biomarker protein released from necrotic heart muscle. These are troponin I, CKMB. CKMB is a protein that will be raised first. Then troponin I is a protein that is raised for multiple days. So we will know that how much days before cardiac event has been happened. Troponin I, CKMB, and cardiac imaging. What is the management? Pre-hospital care. When a person is home and from home to hospital, what we should do? Recognition of the symptom, why this is and what this is happening. This is very important for each and every person. Rapid deployment of the medical team, expeditious transportation, implementation of the reperfusion therapy. Then emergency management, control of discomfort, limitation of the infarct size. First of all, you will give oxygen in primary percutaneous coronary intervention, angioplasty, fibrinolysis within 30 minutes of presentation. You will must give fibrinolysis in TPA, streptokinase, RPA, reteplase. Hospital care. What is the hospital care? Should be admitted in the ICU or CCU. Bed rest for 12 hours. Resume upright position with dangling feet within 24 hours. Nothing per hour in first 4 to 12 hours. 50 to 55% coronary, CHO, 30% fats, carbo. This is how you will give her them feed food. 50% carbohydrate, 30% fat. Bedside command, laxative, sedation, diazepam. These are all about MI. I think so. You will know about this. Thank you so much.